Добрий вечір всім. Добрий вечір, Jörg. Ми дуже дякуємо професору Фегерту, по-перше, за те, що він взагалі створив весь цей цикл і домовився з усіма поважними професорами з усіх європейських країн, що доєднались до цього проєкту. По-друге, він сам читав першу лекцію. Якщо ви її не бачили, ми вам дуже радимо її подивитись. Вона є в запису. І буде сьогодні з нами як основний спікер. Декілька нагадувань і правил. Не треба писати ваші адреси в коментарях, бо є окрема анкетка для того, щоб отримувати потім сертифікати. Питання обов'язково пишіть в коментарях, і ми будемо їх зачитувати, і в кінці будемо на них відповідати. І ще, якщо ви не доєднувались до нашого опитування, ми його вже розсилали двічі, і я його публікувала в себе на Фейсбуці. Воно дуже важливе для нас про те, яких тем вам не вистачило, яких тем ви б хотіли більше, кого зі спікерів ви б хотіли ще побачити, може повторно з тих, хто вже був. Тобто не забувайте, будь ласка, відповідайте на наше опитування, воно є у вас в пошті або в мене на сторінці в Фейсбуці. Дуже вам дякуємо, що ви до нас приєдналися сьогодні ввечері. І так, я прошу професора Jörga Фегерта почати сьогоднішній вебінар.
So thank you very much, Katja, for your kind introduction. I am pleased to talk this evening about one of my main topics, child protection, child abuse, neglect, and the avoidance of violent parenting, because we see that these harmful events in childhood may influence the way we react to other stresses throughout the life. But before I start, I would like to first come to our series of webinars, because that's the last webinar in the series, and we will restart in fall. And it was the aim of the European Society of Child and Adolescent Psychiatry to empower colleagues in Ukraine in that difficult situation after the Russian aggression, after the war. And we wanted to do just knowledge transfer by webinars. And as Sir Francis Bacon said, knowledge itself is power. And the stressful situation you are going through might make you feel sometimes powerless. And I think learning for a better service for children and adolescents and their families is empowering, is empowerment. And Benjamin Franklin said, an investment in knowledge always pays the best. So thanks to our partners, these webinars were organized by the European Society of Child and Adolescent Psychiatry in collaboration with the Mental Health Coordination Center of the Cabinet of Ministers of Ukraine, and Oksana often introduced to these webinars, and UNICEF Ukraine. And I would like to thank the whole team for their continuous support. Working together with you was really always a pleasure. And special thank to the interpreters that have been really very instrumental. It was absolutely helpful to know there's somebody who can really react in every situation and translates everything. The program is implemented within the framework of the All Ukrainian Mental Health Program, How Are You? The initiative of the First Lady Olena Zelenskaya that I met in Berlin together with our First Lady, Mrs. Büdenbender, in Berlin. It's accredited by the Medical Chamber of Physicians in Baden-Württemberg, and we had during the last meetings more than 600 people that participated live on Zoom and watch the videos on Facebook and YouTube. So we had more than 1,000 registrations, and all videos are available on YouTube. And I can tell you that we have requests even from Africa of people who want to see these lectures because they find it very helpful. So some statistics, we had a broad, mixed interprofessional audience, and I also think that it's very important to form a workforce that supports children in Ukraine. We had a third of doctors of various specializations, not psychiatrists, 20% psychiatrists, 28% psychologists, 30% nurses, and 3% mostly scientists, professors, and students of medical universities and colleges. We, as Katja already said, are planning a continuation for autumn 2025, and therefore we are keen to get your responses on the survey, because we really want to serve you. So when we have the data from your side, we will approach experts all over Europe to give the webinars in a new webinar series for you. So we will also send out an evaluation survey to all attendees. And I just want to thank all the presenters, Dennis Ugren, Andrea Denese, Paul Plener, Anne-Marie Rauberg-Christensen, Anna Kovalova, Sven Bölte, Tobias Banaszewski, Ben Vitiello, Beate Herbert-Stahlmann, Chris Corell, Katrin Skala, Kerstin Paschke for their intervention. In Germany, we often use citations from Johann Wolfgang von Goethe. Knowing is not enough, we must apply. Willing is not enough, we must do. And that's what I hope that you are doing, that you are making use of today's webinar. In my workplace, I have a clinical department of child and adolescent psychiatry with a large outpatient unit, with psychotherapy unit, and some inpatient units, but we also have a huge research department, and we get research building from the federal government and the state of Baden-Württemberg to do more lab research in the inflammatory consequences of early childhood trauma. This is the building, it's finished, and we are about to get into the building. Another special point of my department is a group that focuses on dissemination. We have a lot of web-based training courses, and at the moment, in cooperation with another branch of UNICEF in Ukraine, we develop an e-learning program on trauma-informed care of children and adolescents. And we have the center that rules the Medical Child Protection Hotline. That is an information service, and WHO mentioned in their report our hotline as an example for the whole European region, and I would be glad to support you if you would like to develop something like that in Ukraine. We have a team of trained physicians, of pediatricians, of child psychiatrists, of forensics experts that you can call all around the clock, 24/7, and they give personal advice in cases of potential child abuse. And I'm very lucky that this hotline for physicians and social workers has now been regulated by law, and will be institutionalized for the future. It has been a model project from 2017 to now, and now we are in the law, and we will be there for the future. So the outline of my program this evening is growing up without violence is one of the aims of the Sustainable Development Goals of the UN. And I will talk about this importance for building up societies that are just and allow participation of everybody. Then I will talk about definitions of child maltreatment and neglect, and I will talk about the prevalence of child maltreatment and neglect and the consequences of child maltreatment. And I will stay this evening in the analog world, the direct abuse, the direct questions of child protection. I could offer in the next series, if this is interesting for you, another presentation on digital abuse in social networks. We just published last week a paper in the professional journal Child Abuse and Neglect on internet solicitation and abuse, but this would be much too broad to bring everything in one webinar this evening. So let's start with the aim of growing up without violence. The aim is to increase resilience and well-being in children, and violence in upbringing is inhuman treatment, and the European Convention of Human Rights rules in Article 3 that we have to bring up children without violence, and state parties should take all appropriate legislative, administrative, social, and educational measures to protect the child from all forms of physical or mental violence, injury or abuse, neglect or negligent treatment, maltreatment or exploitation, including sexual abuse. And we have also in the Charter of Fundamental Rights of the European Union the right to freedom from violence and the right for the well-being of the child. And if we look at the Sustainable Development Goals that the UN developed after the Millennium Goals, we have this Goal 16, peace, justice, and strong institutions. And within that Goal 16, there is a Goal 16.2 that is called End Abuse, Exploitation, Trafficking, and all forms of violence and torture against children. So on an international, global level, we have an agreement to promote peaceful and inclusive societies. It is necessary to fight child abuse and child violence, violence against children. And even there have been designed indicators for monitoring of abuse in a society. And we did a lot of research with the third indicator, the proportion of young women and men aged 18 to 29 years who experience sexual violence by age up to age 18. And this is very important because that is a field that is changing very much by the internet abuse. Therefore, we really have to ask the youngest generation to find out what is really going on in the internet. So if we go to definitions of child maltreatment, there are plenty of definitions, and it's in part difficult to find out what classification you might use. So I will focus on a UNICEF classification because we work together with UNICEF, and there is that classification published in 23, the ICVAC classification, the International Classification of Violence Against Children. And this classification is different from other classifications because it includes the homicide of a child. And UNICEF argued that this is just like an indicator of the maximum of violence you can have on a child, and that it should be included into public reports on violence against children. And then they have physical violence against a child, sexual violence against a child, psychological violence against a child, neglect of a child, and other acts of violence. There has been a European project to find a consensus in 34 countries in Europe, and they tried to define child maltreatment, and they said child maltreatment is a subtype of violence against children. The perpetrator can be an adult or a minor, but this person has to be in a position of power over the victimized child. And to define an act or an omission as child maltreatment, it must cause harm and have the potential to cause harm, regardless of the intention, severity, chronicity, or the traditional cultural beliefs of the perpetrator. And the most common definition had been developed in a long consensus process in the US, where medical doctors and social workers sat together to find a common definition of child maltreatment and a classification. And they distinguished maltreatment as active acts and neglect as omission. So in the maltreatment category, you find physical abuse, emotional abuse, sexual abuse, and in the neglect category, you have neglect of care and lack of supervision. And today, and therefore I choose this theme today, in Germany, we have the Day of Nonviolent Upbringing. And we just did a study on the attitudes in the German population. And in the year 2000, we introduced to our law, and at that time I testified as an expert at the parliament, that education has to be without violence. And at that time we had a political debate, and many politicians said, oh, that makes no difference because people will not shy back from beating their children if there is no sanction, if you just say you should not beat a child. But we have seen many changes, and I will show you. But I think people are aware of physical abuse and of sexual abuse, but many people, even specialists, ignore the harsh consequences of emotional abuse. So if parents terrorize their children, isolate their children, have a hostile rejection of the child, exploit the child, then there are high risk of psychiatric consequences in the further life of these children. So we have these two groups, maltreatment, neglect, but often these forms are combined, as we will see. So we come to the prevalence section. And in one of these reports of the WHO for the European region, they took results from general studies on prevalence and talked about and calculated approximative numbers for all Europe, not the European Union, but the whole European region. And they said that at the moment we are talking 18 million children are affected by sexual abuse, 44 million children are affected by physical abuse. 55 million children are affected by emotional abuse. And 90% of all cases of abuse go unrecognized by professionals in institutions. So we have a lot to do to discover these children and to protect these children. And WHO in the same report says that child protection is the field in medicine where we can have the best gain for invested money, because until now our social system and our medical system is so ignorant of this major problem that small changes can realize big results to the benefit of children. I'm here in Bern because a psychologist from my department, Andreas Witt, who is now head of psychology at the department in Bern, today had his introductory lecture at the university. So it was a pleasure for me to be here. And Andreas Witt organized a nationwide representative survey in Germany with the childhood trauma questionnaire that you might perhaps know. And in the childhood trauma questionnaire, you have a broad definition of abuse. You have moderate to severe, and you have the extreme forms of abuse, like sexual abuse with continuous penetration, oral, anal, or vaginal. And what is important for me is not the details of the figures, but to show you the dimension. In many studies, worldwide studies, we see that these forms of abuse, if you take a broad definition, are really relevant for harm in about 10% of the total population. And if we only take the most severe and extreme forms of abuse, we are still in a range of 2 to 3 or 4%. And these are really very, very big numbers. If we go on to the prevalence of neglect, the prevalence of neglect is even higher. But you see that in comparison, the figures went down between 2010 and 2016. And this has to do with the fact that after the war, the older generation in Germany, after the war, grew up with a very difficult situation, and there has been quite a lot of neglect. And in the younger age groups, the rates of neglect are lower. But the next figure shows you that if we compare these German numbers to international comparison data, there's a Dutch group that made a meta-analysis. We can say for sexual abuse, emotional neglect, physical neglect, we are more or less on the same range. If we took here a more strict definition, therefore the figures are a bit lower. But the main message is abuse and neglect is very frequent. And to give you a feeling of these numbers, in Germany, the prevalence of type 2 diabetes is about 7%. So if you think around in your colleagues, your friends, your family, the number of people with diabetes you know exactly the same proportion of people that live through sexual abuse, you know, but they don't talk about it at normal social interactions. There's a new instrument that I can really recommend to you, the ICAS, developed by the International Society Against Child Abuse and Neglect. And the advantage is that this instrument poses much more detailed questions. And the more detailed you ask on a behavioral level, when you really ask about behaviors, observable behavior, the numbers of maltreatment go up. And if we look for the different types of abuse, to the most identified perpetrators, you can see that emotional abuse is mostly something that happens in the family between parents and the child or siblings. Physical abuse also is a phenomenon that runs in the families, and the same mostly is correct for sexual abuse, but there also peers play an enormous role. And this figure should show you that if a person had been confronted with emotional abuse, there is a much increased risk also for physical maltreatment. We have a 37-fold higher risk for physical maltreatment, a 15-fold higher risk for sexual abuse. And you see that the co-occurrence of different forms of abuse is the rule and not the exception. So in our studies and in our clinical work, we usually explore the adverse childhood experiences according to the concept of the ACE group of Dr. Felitti. And in this concept, you have on the one side the forms of abuse I explained to you: emotional abuse, physical abuse, sexual abuse, emotional neglect, and physical neglect. And on the other side, you have the household dysfunctions: mental illness in household, substance abuse in household, partner violence, imprisonment of a person in the household, and separation of the parents, especially if there are long disputes between the parents. I think this list is not perfect because we should add bullying in school. We should add traumatization by the consequences of loss due to war and things like that. But this list of 10 items give you an orientation. We published the first study on these adverse childhood experiences in a representative sample of the German population. We examined 2,500 people in a household survey, and we found frequencies of 12% emotional abuse, 4% sexual abuse, 9% physical abuse, 13% emotional neglect, and 4% physical neglect. And as you all know, mental illness of a parent is quite frequent. Domestic violence is quite frequent. Alcohol abuse is very frequent, and even imprisonment of a family member is frequent. And now the important message is, if you had 4 or more of these adverse experiences, you have much more consequences of these experiences in your future life. And if we look at these consequences, if we ask people how satisfied they are with their life, you see there's decrease like in a titration curve. And people who survived 4 or more of these stressors have much more problems in their life and less life satisfaction. This is highly significant. If we look for depression with a screening like the PHQ, you find an increase, again, like a titration curve. The same is true for aggressiveness. And often people think that victims are more or less shy, depressed, anxious, but there is also a reaction to aggression by becoming oneself aggressive. And there was a 10-fold increase of physical assault in the last 12 months in the persons who had 4 and more adverse experiences. And verbal aggression is also correlated with the experience of these adverse experiences. And as you see, life gets complicated if you suffered from so many relationship problems in your childhood. You can see that the relationship status also depends, and that only 28% in the group of with 4 and more adverse childhood experiences lived in a relationship or have been married. So the person that developed that concept is Dr. Vincent Felitti, who was a specialist in internal medicine, and he worked at an insurance company at Kaiser Permanente in the US. And he wondered why some of his patients really have relapses and really have so many risks. And he found out that much of what is recognized as common in adult medicine, so these physical consequences, is a result of what is not recognized in childhood. And he said that child abuse and the other adverse childhood experiences have far-reaching psychological, somatic, and socioeconomic consequences. And general practitioners and all healthcare professionals have a central role in trauma-sensitive intervention and dealing with the consequences across the lifespan. For example, the German military did surveys on soldiers and their psychological traumatization after being at war in Afghanistan. And those who had experienced a lot of childhood adversities were at much higher risk to have a severe post-traumatic stress reaction after being confronted with the war. So also in the anamnesis of parents, it is very important to ask about these things. And we have seen that in the pandemic, that young people with pre-existing adverse conditions had also much more difficulties to come through the pandemic. So it's a very important concept to understand resilience or vulnerability in stressful situation. And as you are going through a permanent stressful situation at the moment, I think it's very important to have a focus also on these risks that you can change and that you could be able to handle. So what is the concept of the long-term consequences of these ACEs? It starts with negative childhood experiences in this pyramid, and that's a slide from the Centers for Disease Control and Prevention in the US. And these negative childhood experiences lead to a social, emotional, and cognitive impairment during school age. And from puberty, some of these persons start with risky behaviors, with drinking, with drug abuse, with gambling, as we had in the last webinar. And this risky behavior, especially drug and alcohol abuse, introduces other problems, illnesses, disabilities, social problems. Heavy eating is also one of the stress reactions. And these things combined can even lead to early death. So we already talked about trauma-related disorders, but I just want to remind you that childhood trauma can lead first to acute stress disorder, but some of the children go back to a normal development, and we call these children resilient. Others might develop post-traumatic stress disorder or small children attachment disorders, especially attachment disorders with disinhibition, depression, suicidality, risk behavior, substance abuse, physical diseases like obesity, cardiovascular diseases. And we have the risk of transgenerational transmission, so that the victim of abuse thinks that that's the way how you educate children, and they tend to harm the next generation by beating their children. In our Trauma Research Center, we did some research on association of child maltreatment subterms and long-term physical health. And you see that blood pressure, overweight, alcohol abuse, diabetes, cancer, stroke, heart attack, all these very common things in adulthood are related to the number of traumatic, potentially traumatic events you lived through in your childhood. The same is true for diabetes, cancer, stroke, heart attack, and COPD if we look at the CTQ criteria. So we could replicate the data from Felicity's group. We also found that child maltreatment increases the risk of non-suicidal self-injury and suicide attempts through impaired personality functioning. And therefore, I always say that in our anamnesis, when we talk with patients and we take their history, it's important to talk about these issues. For a certain time in my department, we regularly gave out a questionnaire on potentially traumatizing events, and about 50% of our recourse population presented with at least one potentially traumatic event. So this is not rare. And if you have the selection bias of a special institution, of a child psychiatric ambulance, it is really very, very frequent, and therefore it's important to ask for it and to screen for it. Today, as I said, is the day of nonviolent parenting, the 30th of April, and therefore I will end with the observable parental behavior. And I think I'm a grandparent now, a grandfather now, but many of you are direct parents, and it's worth to think about your own behavior. And this year we have in our laws, in our German Civil Code, 25 years of non-violent parenting. And the very important message is that attitudes of parents have really changed. The narrative of the one slap in the face that has never harmed anyone is more and more disappearing in our society. And we just finished a new representative survey, and we had a press release today, and the complete study will be published in autumn, but I will show you some first results. And just if you look at it, you don't have to read the figures, but you see with the red lines the enormous decrease of what parents think is an appropriate approach in disciplinary measures from 2001, when the law came active, to 2025 to now. So the legislature can really change attitudes of parents, and this changes, for example, parents' attitudes as a playground. Because before 2000, many parents thought raising a child is a private thing, and I will not discuss with other parents about their parenting behavior. This has changed completely in the German society. So parents that beat their children, that cry, that bully their children, that harm their children, are now much more confronted by the bystanders, by the other parents around. And we quickly go to the decrease in the different categories. So the sentence, a slap on the bottom has never harmed a child. Only a third of the German population now thinks that they would subscribe this phrase. Only 40% would say a slap on the bottom has never harmed a child. And only 20% would say, the next year, a slap in the face. Only 17% would say a slap in the face has never harmed a child. And if we go to the severe forms that come near to maltreatment, like severe spanking, the rates get very, very low. And now there are data from an older publication in 22, so 20 years after the introduction. We asked today's parents about their experiences during their education and their behavior and the acceptance of these measures. And you see a huge difference between those who had themselves experienced corporal punishment or other forms of abuse, and those who did not. So we see here the cycle of violence. And this is also true for the experience of emotional violence. Those who experience emotional violence in their childhood have a higher risk to abuse, also to corporally abuse their children. And if we look at emotional punishment, we see that shouting at a child is still the most common form. Then we have blame, humiliation, belittling, demeaning, hurtful, insulting statements, intimidation, locking up a child in a room, withholding a meal, leaving the child home alone, where all the others go out, isolation from family or friends, not talking to the child anymore for a certain time, and other forms of emotional punishment. And I think it's very important to have a focus on these things, because even in your everyday practice, if parents come with their children, you can observe these behaviors and can confront the parents and talk with them. And when we really ask what kind of forms parents used in Germany, we talked about attitudes, now it's the real behavior. Half of the population said that sometimes they shout at their children and intimidate them. 10% sometimes called their children to be stupid or useless. To ignore a child is quite common. To lock them up also reaches 20% in the general population. And the threat of corporal punishment is also quite common. So we also looked at this transgenerational effect, and if parents experienced emotional abuse before the age of 18, the risk that they will use emotional punishment when raising their own children is nearly 3.5 times higher than for parents who did not experience emotional abuse in childhood and adolescence. So this reflects that cycle of violence. But in that older study, there's also a good message. If parents reflect their own education they got and lived through, and think that they want to really change it to raise their children in a different way, you don't see these effects of cycle of violence. So it's not a self-fulfilling prophecy, it's a question of attitude, and we can change attitudes, as you see every day. So I come to the conclusion. All forms of child maltreatment, and these are the take-home messages, are very common. The long-term consequences are significant, and they really pose risk to child's well-being. There is a current or at least imminent danger to the child's development, and significant neglect and psychological abuse are a permanent challenge for professionals in child protection and all medical and paramedical professionals, psychologists, and social workers. So we have to see that these findings on the long-term course of adverse childhood experiences are relevant for the prognosis of a child's welfare risk and of an adult's reactions to today stress. There's the concept of the second hit. Our surgeons in our department, and we narrowly work together, often don't understand that people that are harmed in a car accident with very similar fractures can react so differently to surgery and rehabilitation. And then when we go into the anamnesis, we see that those that are more impaired by the second trauma are those that survived childhood adverse experiences. So it's a key factor for the individual prognosis, and the combination with other stressors makes the full history. So it's really important to take the history of the patients and not to focus on individual actions, but to have an overall view of the stressors, like also bullying, mobbing within peers, and violence among siblings, and all the forms of stress and violence in the internet. But this is not the theme today. What is also very important is to see that the patients that survived these adverse experiences are at high risk for re-victimization. So in potentially stressful situations, they need support and a special respect. And as I told you, we try to really inform the doctors in their daily work by that hotline and by a lot of information programs, because in every part of practical medical work with children, be it as a surgeon, be it as a dentist, you can be confronted with abuse cases. So everybody should have the possibility to ask a specialist what to do next. And I think that is one of my most important projects, that I was able to build up that child protection hotline for all the professionals in Germany. And given the specific challenges arising from the ongoing situation in your country, a similar specialized counseling for dealing with traumatic situation, for dealing with grief and loss of a parent, for dealing with separation and war-related stress could be helpful for all of you, because I see your huge interest in these webinars. But one side is teaching, but getting into action sometimes needs some sort of supervision or an exchange with colleagues. And I would find it wonderful if you would be able to organize something like that for all your interested community, to the best of the children in Ukraine. In Germany, this hotline is free of charge, available all around the clock, 24/7. And we do an annual meeting. And the last annual meetings, when not only in presence, but were webinars. And usually it's in the end of summer, end of August, beginning of September, and we now reach more than 4,000 or 5,000 medical specialists that are interested in the questions of child protection. And I think we really have been able to build up a community. And this year we will talk about child protection as an emergency in medicine and child and youth welfare, because also the emergency people that find patients in a home, intoxicated patients, often have worries about children. And I think it's also a very valid approach to talk about child protections in emergency departments. So that's the end of my talk. Thank you for your attention. I come from Ulm, and Albert Einstein was born in Ulm. And as he said, there are no great discoveries in progress as long as there is still an unhappy child on earth. And there are so many situations at the moment to be unhappy. I hope that we can contribute with our work to give children a chance to grow up in a better world. Thank you very much for your attention.
Дякую дуже, Йорг. Бачу багато коментарів від глядачів про доказову, структуровану і дуже важливу інформацію і взагалі про те, що ви допомагаєте Україні. Одне з питань, чи можна користуватись цією презентацією? Чи ви дозволяєте користуватись цією презентацією?
Yes, of course. Yes, of course, yeah.
І тоді я не бачу поки питань від аудиторії, але в мене є декілька запитань. Запитання перше таке. Наприклад, якщо ви в себе в відділенні, там приходить до вас дитина, поступає дитина, і ви бачите, що є якісь ознаки насилля того чи іншого типу. Яка процедура, що ви або медична сестра, або будь-хто в лікарні повинен робити? Як далі все це відбувається?
So it depends on whether the child is an outpatient or an inpatient. If we have the child as an inpatient, we have more time. And we have a safe situation when we explore the behavior and when we confront the parents with the question, because we have to talk about that behavior. If it's an outpatient and the child goes home with the parents, we first have to see how we can find a safe situation to see the child again, to have a look on the course. But what is very surprising, and that's also the experience from our child protection hotline, is that many parents are open to speak about that. And in our country, the regulations of the medical secret give them an open space where they don't have to fear to be confronted with criminal charges. We can just offer them help and support. And often we start to talk about the problems of the mother or of the father. And it's the alcohol abuse of the father. It's the domestic violence interpersonal violence between the parents. So there are many issues connected. But the important thing is, first of all, is to listen to the child, to document it, but don't confront parents if you are not sure that you can protect the child. Because if the child goes back with the parents and gets punished, it will be very difficult to speak again about that. So there has to be some checks and balances, especially with outpatients.
Друге питання про тих, хто працює на гарячій лінії. Хто вони, хто їх тренує і як, і наскільки часто вони самі потребують психологічної підтримки після того, як працюють на лінії?
So all the people working at the hotline in the front line are medical doctors, and we replicated the structure of a hospital. So these medical doctors are trained in different specialties, in pediatrics, in child and adolescent psychiatry and psychotherapy, and in forensic medicine. Behind them, there's a second line of experts, of professors in child psychiatry, in pediatrics, in forensic medicine, and also in psychotherapy and in social work, and they are lawyers. So if there are complicated problems that they can't solve immediately, they have backup a professional backup. And the doctors working at the hotline only work on usually only work on half time posts. So the other time they work in the hospital or in private practice, because we want to have colleagues that are credible and that know the real life situation. It's not an education of an expert, but it's really a talk between colleagues on the case. All the doctors, in addition to their professional training in the medical field, got training in social work and training on the legal conditions. And many questions are really about the legal situation. Do I have to report? What do I have to do? So this training is essential because the doctors can listen with the ear of a doctor, so the communication is easy, but they can inform about the legal situation and the potential reaction and help we can give. Then everybody has personally access to supervision, but we also have group supervision for the team. And we have an online platform where every case is documented, and we have regular seminars and meetings where we discuss the cases and have interaction, because the doctors that are working for the hotline are sitting in part in Freiburg, in the south of Germany, or in Ulm, also in the south, but also in Berlin and in Hamburg. But with our regular contacts, it's really now a team that knows each other very well, and they are very open. And we discuss many cases, but they also have supervision without me as the head of the department to talk about their personal problems with that work.
Як фінансується ця лінія?
The hotline is financed by the government. I made a proposal to the government for such a hotline, and they declined that proposal. Then I convinced members of parliament, and finally the budget group of the German parliament gave the Ministry of Family Affairs money to implement that hotline. And then they made it a model project, and it was evaluated 2 times by an independent institute evaluator and by the WHO. And now after a phase of 7 or 8 years, there was a law in the parliament. We got a paragraph in the child protection law, and we are now regulated as a permanent offer to the professionals. So the federal government has to pay for the hotline, and the doctors get normal salaries. We organize that with our hospital managements, but the money comes from the central federal government.
І в нас є...
It's just about $1.5 million per year, covering the whole country with 3 specialties. So I think it's a small investment for a big improvement. Therefore, I recommend something like that for you, for all these difficult situations in the stress and trauma context, because in your practical work, you need sometimes the chance to talk with a person that is very good informed in that field and acts like a colleague, yeah, and can immediately give you some ideas for your cases.
Є питання також від глядачів, задаю їх, як вони є. Пані Ольга Любчич питає, чи є курси по підготовці фахівців або матеріали з ненасильницького батьківства?
Yes, we have developed a huge number of courses. Most of them are in German, of course. We also have a Swedish course supported by the European Union. And these e-learning courses, with these courses, you can earn about 60 to 80 credit points from the medical JAMA in Baden-Württemberg. The same certificates you get for our meetings, but much, much more points. During the Corona phase, that was the only thing people could do to earn their points for continuous medical education. We really scaled up these programs, and we trained about more than 70,000 physicians in Germany who passed their exams and got certificates in child protection. And I'm very proud about that. Yeah. We have no Ukrainian version. I suggested that very, very early to Dr. von der Leyen when she called me how we could support Ukraine, and she was about to meet Mr. Zelensky on the Day of the Child. And I thought that these e-learning programs could be very helpful, but I have to admit all the legal background is different in your country. So there has to be a national investment in that, an adaptation. But if you speak German, I can give you access to all our programs if you are interested. We have programs in trauma care, in child protection, many programs in this field.
Пані Ольга Пучина пише, за законом в Україні не може зайти поліція в помешкання без дозволу. Як це питання вирішується в Німеччині у випадку насильства над дитиною?
So it's the same. The police normally can't enter the safe space of a family, but if there is really imminent danger for the child, they are allowed to do so. Social workers are not allowed, medical doctors are not allowed. They have to go to a family law court and to get a court order to enter the family. But often we see these children in situations at school where they don't want to go home and report to an educator, to a teacher, where they establish a relationship. So you have them in the public ground and you can bring them to an ambulance and talk with them in a medical setting. And you know that Her Majesty the Queen of Sweden was very engaged in child protection. And you have in all Scandinavia that concept of barnehusets, of children's houses, where diagnostic and first support can be done at one place in a medical hospital. And in Germany, we have more and more these model projects at the local level. And that might be also a model for you. This is supported by the World Childhood Foundation that was funded by Queen Sylvia.
Наступне питання, увага, перекладачі англійською, тому я його і буду задавати англійською. Would you be able to comment on potential difference in later life consequences of early childhood trauma between neurotypical children and neurodiverse ones? Is there such statistics like you provided somewhere to look at?
Yes, that's very good and also a difficult question, because what you call neurodiversity might be ADHD, might be ASS, and we know that one of the consequences of early neglect is a problem in coordination and suppression of impulses. So there is no strict separation of the two phenomena. And we often have children that appear like children with ADHD at a certain age, often at primary school age, that had been severely neglected during their early development phase and have a very, very high risk to start with abuse, drug abuse, and to develop personality disorders. While as other children with more genetically defined neurodiversity just have their normal course. Yeah. But if you look only at the phenomenological definition of ADHD, you can classify both ADHD. And therefore, I think it's very important to have a good history and a very good clinical view.
Пані Тата Дворяковська питає, чи існують опитувальники, які можуть виявити психологічне насильство в тих випадках, коли дитина не розповідає з тих чи інших причин, що вона жертва психологічного насилля?
Yes, I think there are a lot of questions on emotional abuse, but this is a behavior that is much more observable, for example, in your practice, in your daily work, because you see parents interacting with the child, and a mother that says, oh, it always takes it wrong. He will never learn to do this, and shouts about the child in your presence. Yeah, you can imagine what happens at home. So usually sexual abuse you will never see in your practice. They will not do it in front of you. But emotional abuse, you can really observe. And often it's the nurses, it's the people that are in the waiting room that observe this behavior, not the doctor within his 5 or 10 minute frame. Yeah. Therefore, it's really very important that in an interdisciplinary exchange, we work together and we sensitize our co-working people to see these problems.
Пані Анна Сілаєва питає, як в Німеччині реагують в контексті лікарської таємниці, коли дізнаються про сексуальне насилля над дітьми?
So there is no differential regulation for sexual abuse. It's for all forms of abuse. There is no obligation to report in the criminal context, but we don't breach the medical secret if we report to the child protection services. So it's not an accusation, but we are allowed to inform when we see that with our means as medical doctors in a hospital, we can't bring enough help to the family. And usually these cases go to the youth welfare services and to the family courts. In Germany, we have no obligation of criminal reporting. And this is very different from the states of common law like the US or the UK, where reporting is mandatory. But it has been observed in some states of the US who introduced mandatory reporting for doctors, that the numbers of reporting went down. And the aim of the German system is to bring help to these children. So the focus is on the assistance of the child and the social support of the child, and not on the criminal system. So it's a decision of every doctor whether he thinks he wants to depose a criminal complaint, and that's very rarely made. We have some delicts in our law court. So if you prepare an attack with a bomb, a terrorist attack, then doctors are forced to file a claim in the criminal field, but not for these intrafamilial sexual offenses, because often the result is the cover-up and nobody talks about it, and that's what they fear in our system.
Наступне питання від пані Діани Сушко. Є підлітки з розладом дефіциту уваги та гіперактивності, ADD, HD, і коморбідно з опозиційно-викличним розладом, ODD, які виховуються в звичайних сім'ях. Ці підлітки можуть чинити психологічне насилля стосовно своїх батьків. І вони завжди демонструють високий рівень опозиційності, не відвідують школу, обзивають батьків, можуть приходити додому дуже пізно. Батьки зазвичай дуже виснажені такими дітьми і часто мають депресію. Як комунікувати з такими дітьми без використання демонстрації наслідків їх поведінки?
Yes, I think this is often a problem of parenting at an earlier age, and you know programs like the Triple P program. I think many of these parents are not very consequential in their reactions to the behavior to the child. And sometimes you come to the point where you have to separate the child from the parents because these children are menacing the parents. They don't go to school. They are at high risk for criminal behavior. And sometimes we have orders from the family courts to treat these children and to try a restart with the family in a coordinated setting. So we do parent training at the same time, and we take these children into a group context. And I think this is often very helpful to these children because other children have a very good feeling about what is okay and what is not okay, and they directly give a feedback. Yeah? So these situations, especially with depressed mothers who can't react to normal positive behavior of children and who react to this problematic behavior, really reinforces that situation. And sometimes it's better to get a separation for a certain time.
Ще є питання про те, в яких ще країнах є така гаряча лінія.
No, I don't know a comparable project in any other country. Therefore, WHO mentioned us in that report as a good example. The Dutch colleagues have another very interesting project. They have a medical communication system where they can look at radiology pictures, at pictures, forensic pictures in teams all over the Netherlands to do a common expertise on a medical finding. So this needs technical support and data protection things, and I think this is very helpful. That's what we can't do in our hotline because it's a counseling and it's a dialogue between colleagues. and we don't get the data of the patients. We don't get really radiology pictures and things like that. But this approach in the Netherlands is also a very modern and very valuable approach.
Тоді ще два питання від мене. По-перше, що з біженцями? Як така лінія, наприклад, працює з біженцями з інших країн, які перебувають до Німеччини? Або ви не бачите їх через призму цієї лінії?
We see all the patients indirectly. So we see the patients that are seen in the field, in the hospitals, in the private practices. So we don't have the communication problem with refugees. This problem has to be solved in place. It's not a hotline for the children. It's a hotline for the professionals. There are other hotlines and offers of chat like crisis chat. They have Ukrainian branches. Also our hotline for women in danger, they have Ukrainian counselors and counselors in many languages. So there are direct offers, and then there are also translation services. But in our hotline, we don't need it because we just do counseling for German experts.
І друге питання. Ви часто говорите команда спеціалістів. Спеціалісти, колеги розмовляють один з одним про якийсь кейс. Наскільки давно ця традиція працювати командою з пацієнтом з'явилася в Німеччині? Бо в Україні це досі не дуже часто, і доволі часто це все ще така війна его різних. Я кращий професор, ні, я кращий професор, я краще все знаю.
I think we have the same problem in many places in Germany. And I think that's the reason why working in that hotline is so attractive. You might imagine my co-workers in the hotline during the last year until end of November, they did not know whether they would have a contract from January because the political decision on the hotline was not yet achieved. Our government collapsed and it was a complete insecure situation. None of the doctors left the hotline. They all could have a better job, better paid job within a week because there is a lack of doctors. But what they find in our hotline is an exchange with colleagues and even an exchange with social workers, lawyers, and working together and discussing the cases. And young doctors are really keen on that experience. And I think we as heads of departments, we have to learn that we should organize medicine in a different way. Because we can learn so many things from different perspectives. Yeah? It's really a challenge in the way how we combine our expertise, our narcissism as professors, and the exchange between colleagues. And I think there is place for both sides, but to the best of our young doctors, we need more exchange.
Я дуже дякую професору Йоргу Фегерту за сьогоднішній вебінар. Всім нагадую, що наступна серія почнеться, і нам потрібні відповіді на запитання стосовно тем, які ви хочете. У вас цей опитувальник був в імейлах від нас, будь ласка, дивіться, або він розміщений в мене на Фейсбуці, Катерина Булавінова, ви заходите на мою сторінку, і там також є лінк на цей опитувальник. Будь ласка, напишіть нам, які саме теми ви хочете в нашому другому сезоні цього серіалу. Тому очікуємо на ваші відповіді. Ще раз дуже дякуємо Йоргу Фегерту за сьогоднішній вебінар.
Thank you and stay safe. Yeah. Have a good time and I'm glad to see you again soon. Bye.
Bye.